Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, dear MRCOG Part 3 warriors. This is another short video. I hope this will support your exam preparation. Let's not waste your time. Today we will discuss unscheduled bleeding in women on HRT. This topic, based on recent joint guideline, as you can see, created by the British Menopause Society in collaboration with multiple health organizations like our RCOG, the Royal College for General Practitioners, and other organizations. So today it's going to be a special type of a structured discussion, actually. We will be asked to present our applied clinical knowledge in the form of presentation. And our audience, as you can see, are general practitioners. So we're going to ensure demonstrating key safety points clearly while maintaining healthy communication with our colleagues. As you all know, any topic we can face in the exam as structured discussion, submitted patient task, or as teaching case. So practice to challenge yourself and practice each topic in the 3 different type of stations. So for today, let's see how are we going to deal with this type of exam question. All right. So as usual, we start our introduction. I'm Iman Boussawisi. I have read my task and I'm ready to discuss my presentation. Okay, Iman, how do you think about this presentation? Unscheduled bleeding in women on HRT is an important topic for general practitioners, given the widespread use of HRT, and balancing patient safety with minimal stress is crucial. So here usually we start our discussion by a short introduction about the topic and clearly demonstrate the main point of the topic. So here the main point that we need to discuss is the balance between patient safety, which is crucial, given that the unscheduled bleeding can be a red flag sign of cancer endometrium. However, we should try to minimize the stress so not to disturb the low-risk patients who has the usual common actually complaint and innocent, and we can manage it clearly. So let's proceed. I will prepare my presentation to be engaging with positive vibes by keeping the lights on for alertness and including clear diagrams and interactive slides. I'll encourage questions, offering evidence-based answers, and will seek feedback by the end of it. So as you can see, this is the main idea of the teaching stations. The content will be simple and clear, supported by relevant graphs, tables from the guidelines and recent articles, with essentials link provided at the end of our discussion. Now, the presentation will begin with 2 or 3 background slides featuring tables on HRT indication and contraindication. And a very important topic or item will clearly demonstrate the special circumstances where HRT should be prescribed by specialist or maybe also an MDT. These patients, such as patients who has active liver disease, history of breast, endometrial, ovarian cancer, or history of venous thromboembolism. Additionally, it will include also table describing different administration routes and details of HRT regimens. This includes sequential HRT and continuous combined HRT, and how to navigate between them. For example, a woman using sequential HRT who are over 45 years should transition to continuous combined HRT after 5 years or by the age of 54, whichever comes first. Now, a very simple information, however, very important, and I know that most of you would think that this is silly. It's like basic information. However, please do not assume that the examiner knows that you have this information in your mind. So clearly speak it up. The dedicated slide will emphasize that progesterone must be included for patients with a uterus, regardless of the route. It's not only progesterone should be included, it should be included in the proper duration. So it is 10 days of norethistron or medroxyprogesterone acetate and 12 days for micronized progesterone per month. Now, I will start by presenting the main topic, utilizing the flow chart from the 2024 joint guideline that specifically addressed this matter. First step is to triage the patient into high-risk and low-risk group based on information gathering, examination, and investigation. I will clearly explain both the major and minor risk factors of endometrial cancer as part of this process. And of course, dear friends, you should expect the examiner to ask you to enumerate some of the minor risk factor and the major risk factors, so you should be ready by at least 2 or 3 examples. Now, a separate slide presented in bold will elaborate on this classification to help identifying patients who should be referred for the urgent suspicion of cancer pathway. This pathway follows the 28 days faster diagnosis standard. So the indications for referral will include patients with 1 major risk factor or 3 minor risk factors for endometrial cancer. While patients is waiting for their assessment, HRT should be stopped or at least progesterone should be adjusted. Now, for patients who are classified as low risk and so managed under the primary health care, these are our colleagues, the general practitioner, an urgent transvaginal ultrasound should be done within 6 weeks in cases where patients who are taking HRT and experiencing unscheduled bleeding in addition to any of the following: 2 minor risk factors for endometrial cancer, heavy or persistent unscheduled bleeding, HRT usage for more than 6 months, or dose adjustment within the last 3 months. So these are the red flags for the primary healthcare professional to when to investigate and how to investigate. So for the endometrial thickness cutoff value, above which we refer those patients to the urgent suspicion for cancer pathway, these cutoff values are 7 millimeter for patients who receive sequential HRT, and 4 millimeter for patients receiving continuous combined HRT. A patient with incompletely visualized endometrium also should be referred to the urgent suspicious for cancer pathway. Now, in case the ultrasound examination showed normal findings, so the values will not be exceeded, then management will be adjustment of progesterone or HRT preparation for 6 months, after which, if symptoms persist, then urgent endometrial assessment in terms of hysteroscopic or PEPAL endometrial biopsy should be considered. Now, how should we adjust the HRT to reduce the unscheduled bleeding? First, we address adherence and prescription understanding. Then we offer the patient the 52 milligram levonorgestrel intrauterine system to reduce episode of unscheduled bleeding, or to use the oral progesterone rather than the patch. And for the patient who suffers atrophic vaginitis, vaginal estrogen cream should be considered. Well, I hope this video is helpful for you, and I hope you enjoyed this short time. I hope you're going to practice this station by your own. Try to do it in 7 or maximum 8 minutes so that you can give your examiner a chance to ask or to discuss with you any question. Remember to challenge yourself and to practice each station as a simulated patient task, structured discussion, and a teaching station. Waiting for your comments, and I'm waiting also for any questions from your side. Thank you so much for your attendance.